Hello, everyone, and welcome to Beyond the Data, a patient and care partner conversation on myeloma research from our recent conferences of ASCO and EHA. Thanks for joining us this evening. Couple of quick housekeeping slides. We want to make sure that all of you are aware of how to ask questions because your questions matter to us and your feedback matters as well. So please open the Q&A window and that will allow you to ask questions to our hosts and our panelists. And remember, if we don't answer your questions today, please do reach out to our info line. We really do pay attention to those, and you may just see a little recording in the future of answers to your questions moving forward. If any technical issues arise, please use the same Q&A to send questions to our support team, and they'll reach out directly to assist you. You can also shoot us an email at meetings@myeloma.org during the webinar if you're having any technical issues as well, and we'll reach out for support. As a follow-up to today's workshop, we will have the speaker slides and a video replay available. These will be sent to you in an email following this few days. It will also include a feedback survey. We listen and we do listen to everything that you have to say and really do want to hear your feedback. At the close of the meeting, you'll see that feedback survey pop up. And again, if you're not able to get to it right away, this will also be emailed to you shortly after the workshop. Please do take a moment to complete them. This feedback really does matter, and we want to make sure that we are meeting your needs the way that you need them, that's for sure. We would be remiss if we did not thank our incredible sponsors who helped us to bring this information to you today. We'd like to thank GSK, Johnson & Johnson, and Sanofi. And I also would be remiss if I didn't talk to you about support groups. My name again is Becky Bosley. I am a Senior Director of Support Groups at the IMF. And I really think that support groups, they certainly empower patients and care partners with information, insight, and hope. Our shared experiences really do become our shared strength. On your screen now, you'll see a map of all of the states where we help to educationally support different support groups all across the US and beyond. Currently, we have about 155 plus support groups that we do help to educationally support. And we're also happy to help connect you with a group or to help you form a new one if there's not one in your area. So you can scan the QR code there, and you can also visit myeloma.org under resources and support and find a support group. The IMF also has created 8 different shared experience groups, and these shared experience groups are really designed as a supplemental support for specific populations of patients in addition to their local support groups. On the slide, you can see the different options that are available for these shared experience groups, and you can also find that at Find a Support Group on our website as well. Click on the tab in the center that says Special Interest. I have the distinct pleasure of welcoming some of the most incredible folks that I know. I would like to introduce all of you to your panel for today's webinar. I'd like to start with Terry Glassman, myeloma patient. She is a support group leader from Long Island, New York. She also helps me to lead the high-risk group, shared experience group. And second, Todd Kennedy, a myeloma patient and a support group leader from City of Hope in California, along with his beautiful wife, Diane, who is his care partner and also leads the group along with him. And these 3 incredible professionals are also research advocates and do a lot for our community in this space. And the man who needs no introduction whatsoever, Dr. Joseph Mikhael, the IMF's medical advisor, is here to moderate today's panel and workshop. So please, Dr. Joe, take it away.
Thank you, Becky. We adore you. We're so thankful for you and all the work that you do. And I am more than honored to share the stage with these three amazing people. Well, I hope you're comfortable where you're sitting. You have a nice beverage in front of you, maybe a notepad or an iPad to take some notes if you wish, because the next hour and a half is going to be full of multiple myeloma. The plan for today is 5 chapters of discussion of what has really happened recently in the world of multiple myeloma. I know we think of this meeting as primarily being highlights of what's happened at the ASCO, or the American Society of Clinical Oncology, and the EHA, or the European Hematological Association meeting, which we will do for the first 4 chapters. But then even just since this meeting has happened, which speaks to the pace of what's happening in multiple myeloma, we've had multiple other FDA approvals and very critical papers published. And so we're going to have a "this just in" section. I'll channel my inner Walter Cronkite for those of you who can remember those days, and reporter style. We're going to talk about 3 things that have just entered the myeloma space literally in the last month. But as you see here, we're going to start with early relapse and several large phase 3 trials that have guided us in the way that we are going to be treating multiple myeloma now and in the future. Then we're going to spend some time talking about high-risk multiple myeloma. Becky already shared with us that she and Terry lead a shared interest group in high-risk multiple myeloma, and we'll talk a little bit about some very recent data that gives us further hope in this area of multiple myeloma and a better understanding of the disease. Then we're going to turn our attention to what's happening with these bispecific antibodies, which are going to be pervasive throughout the whole of the discussion today. But in particular, this move towards trying to provide them more so in an outpatient setting. And this is going to be a really fun discussion. I'm looking forward to it. And we're going to engage Diane as our care partner today. I'm really looking forward to hearing her thoughts around this. Fourthly, we'll look at some of the data, the research that was presented that is kind of forward-looking. We're going to kind of take out our crystal balls a little bit, look to the future and say, where is myeloma going in the next 5 to 10 years? How are we thinking about new modalities of treatment that are coming? And then, as I noted before, we're going to move to that "this just in" section and share with you about some of the things that have just happened in multiple myeloma. All right, let's dive in. Part 1. Part 1, remember, is early relapse, where we're going to view 3 large phase 3 trials. And quickly, if you're not familiar with that expression, phase 3 means that a drug or a combination of drugs has really moved ahead in its development to the point that it can be compared to the standard of care to see if it's better. So these trials tend to be large with several hundred patients, and they tend to define what the new standards of care can be. So if for a long time we've been using drug A and B together, there may be a phase 3 trial that compares drug A, B, and now C to it, or something very different than A, B. And so we're going to see 3 different phase 3 trials here: the Monumental 3 study, the Majestic 9 study, and the Successor 2 study. And I hope you are impressed at the names of these studies. We have pretty cool names in myeloma, things like Excalibur and Successor, as you've seen here. And we're going to see some really great names of studies as we go through. But it's not about the name, of course. It's about the study itself. So let's talk about this first one, which was the Monumental 3 study, which was highlighted at the European meeting in what we call the plenary session, meaning it was highlighted as the top 6 abstracts in all of hematology, not just in multiple myeloma. And this large trial that I'll show you how it's laid out here is comparing 3 different groups of patients. So patients were randomized who had a relapsed multiple myeloma. They had at least 1 prior line of therapy, and they were given one of 3 things: Teclistamab, which, as I'll quickly remind you, is a bispecific antibody. Bispecific antibody means it has 2 arms. One arm grabs onto the myeloma, one arm grabs onto a local T cell, one of our soldier cells in the body, to help destroy the multiple myeloma. And Teclistamab is unique in that it is the only bispecific antibody we have that targets something very unique on the cell surface of myeloma called GPRC5D. I know it's a license plate. I know it's a mouthful, but it's a different target than many of the other bispecific antibodies that we use. So in arm 1, they got talquetamab with daratumumab, or you may know as Darzalex, which is a monoclonal antibody directed against something called CD38 on the cell, with pomalidomide. So this was you get to see 3 major drugs there. In the second arm, they got the same talquetamab and daratumumab, but without the pomalidomide. And then the third arm, which was really considered the so-called standard of care arm, what we're typically doing, and we very frequently use in relapse, is DPD, or daratumumab pomalidomide and dexamethasone. So you can see in that realm, so the first arm is seeing, is it worth adding talquetamab to DPD? And in the second arm, they're looking at, can we do talquetamab and dara without the pom and see what the outcomes are? And typically in these large phase 3 trials, the goal is to see if there is a better progression-free survival, or what we call PFS. And PFS basically means the time that patients in that arm stay alive and not in relapse. So they're in remission and they're alive until they relapse, or unfortunately they pass away. And then we'll see that these curves start to change their shape. We often talk about what's called the median PFS, which just means the average time that people are in that remission and alive, where half of the patients, if I have 100 patients and the median progression-free survival is 1 year, it means that at 1 year, half of the patients have already relapsed, but half have not relapsed. And so it's that average, or what we call median, down in the middle. So this study then compared these 3 arms in progression-free survival. And just a quick reminder that these were patients that were, generally speaking, not heavily pretreated. So for example, we see that a little over a third of the patients had 1 prior line of therapy. There was a small fraction of them that did have daratumumab, but by contrast, almost all of them had already had lenalidomide. About 85% of them had already had lenalidomide. And here is, drumroll please, here is the key data that we found. When patients got the talquetamab with darapom, it was significantly better than darapom dex. And also on the right hand, patients who got talquetamab and dara alone was also better than the darapom dex. What do I mean by better? Well, let's try to look at these numbers a little bit. I know some of you may not be used to looking at these numbers, and our goal today is to make this patient friendly, and that's why we have patients and partners helping us with the presentation today. But you see that red line, for example, that first red line on the left side of the screen. If that line were completely flat, it would mean that nobody progressed and nobody died. That's our goal. That's the only time we like flat lines in medicine, when there's no change. But unfortunately, every time that line dips down, it means that a patient has either relapsed or passed away. But you can see how the red line is so much more flat than that black line, which is the line where that reflects the DPD. And then because the so-called median, as I mentioned earlier, was not met, we look at a 2-year time frame. So at 2 years, 81% of patients were still in remission. For talquetamab and dara alone, without the POM, the 2-year mark was about 78%, so really quite similar. And of course, you can see for the dara-POM dex, the standard of care arm, it was much lower at only 51% of patients still being in remission at 2 years. This was, of course, driven by a significant difference in the response rate. The response rate for the combinations that had talquetamab were almost 90%, 88%, and were 78% with DPD. So DPD is a good strategy. A strategy that gives over 3/4 of patients a response is good, but you can see the difference. For those who are interested in appreciating what we call MRD, or minimal residual disease, we saw that it's not just responding that matters, it's the depth of response that matters. And whether we look at it with the black or the red bars here on the right, and I won't bother too much about the difference between those two, it's just the degree of sensitivity of the MRD testing, you can see a big difference between talquetamab dara-POM, talquetamab dara, and the control arm, the DPD, where we see numbers almost 50 or a little over 50% with those talquetamab including arms. In the DPD arm, it was only 16%. There was even a trend towards overall survival benefits. So this is the same kind of curve, but now we don't drop the curve when someone relapses. Sadly, the curve drops when someone passes away. And so at 2 years, 89% of patients with TAL-DP were still alive versus 80% in those with DPD. Oh, sorry, someone's jumping the curves here. And so the conclusions that they made were that this is a really powerful combination when we add teclistamab and daratumumab together. POM can be of some benefit, but didn't seem to have a very large benefit. But either way, these two strategies were considerably better than the dara-POM dex. We're going to come back to discuss this with the other two trials in a few minutes. We'll start with Todd and then move on to our other friends here today. Another majestic study compared this time a different bispecific antibody. This time it's Teclistamab. So again, 2-arm drug. One arm grabs onto myeloma, one arm grabs onto a T cell. This time it grabs onto the myeloma by the BCMA target. And now it's just Tec alone. We're not combining with other things. We've seen other combinations with Tec before, like we saw combinations with Tal. But here it's also being compared to the general standard of care, either the combination of carfilzomib and dex alone, or with pomalidomide bortezomib and dex, what we sometimes call PVD. So this is a bit more of a simpler design than when we looked at. It's just 2 arms. You either get Tec alone or you get one of those 2 combinations that the investigator or the doctor chooses with the patient to be treated. And again, the primary endpoint we're looking for here is progression-free survival. Now, in this case, it was a little bit different than the patients we just saw in the previous study. There were, and Terry, I know, was watching this carefully, there were over a third of patients that had high-risk cytogenetics. There were over a quarter, if not almost a third of patients who were over the age of 75. So this is a little bit more reflective of patients that had a little bit more treatment of their disease. But nonetheless, look at the big difference here. At 18 months or a year and a half, 70% of patients with the Tec alone were still in remission versus only 27% in those patients that had the standard of care. This difference between the 2 arms is really quite dramatic for us in multiple myeloma and really speaks to the power of the teclistamab. Now, there were challenges, and I don't have time to go into every bit of it, but there were challenges with infections. We know that when patients receive a bispecific antibody, they're at high risk of infection, partly because their disease is slowing down their immune system, but also we're giving them a drug that depletes their own immune system and doesn't allow their T cells, because of course they're so busy attacking the myeloma, be able to defend the patient. But thankfully, we have been learning how to use the right tools to reduce that risk of infection. We give people IVIG. We may give them antibiotics. We respond very quickly if someone may have an infection. And although there were a lot of infections in this study, we can see here about a third of patients in the first 6 months had a severe infection. That number did decline with time. So we are learning how to use these agents a little bit better, and that becomes really important. So their conclusions were that this was a very obviously positive phase 3 trial, that we saw that Tec monotherapy or teclistamab alone was superior to the combinations that we typically use, and the safety profile, as they call it, or the infections and so on, are what we have known and seen with teclistamab before. All right, the third one, before I call on my BFF Todd here, is the Successor 2 trial. So this is now a different combination, and here we're using a very brand new drug, not FDA approved yet. Both drugs that we just talked about, talquetamab and teclistamab, they are already approved in different settings. Obviously, we expect them to be approved in the settings that we just discussed. But this is a brand new drug called Mezigdomide, sometimes affectionately known as Mezi or Messi if you're a soccer fan. And Mezigdomide is part of a new class of drugs that are called CELMoDs. Now, for those of you who are going to tough it out to the very end, which I expect to be all of you, we will come back to CELMoDs because the very first CELMoD just got approved by the FDA a week ago, like barely a week ago, and we're already talking about it. And that drug is called iberdomide. But for this study, we're going to talk about Mezigdomide, and it was compared in a clinical trial with carfilzomib to just carfilzomib and dexamethasone alone. Now, quickly, these CELMoDs, they're similar, but a bit different than the drugs we use now that you're likely familiar with, Revlimid and pomalidomide or Pomalyst, what we call the IMiDs. The IMiDs, they work on a certain compound called cereblon. And when cereblon gets squeezed, it triggers a pathway of what we call protein degradation, or something that just basically helps destroy the cell. CELMoDs are similar to the IMiDs. They're pills. Typically, we give them for 21 days on and 7 days off, like we do with the IMiDs. But they have a more, and this is why the difference between is an IMiD was the blue dot. Here with the CELMoD, it's like a blue horseshoe. It has a greater binding capacity to that CELMoD, to that cereblon. It squeezes, if you will, the cereblon that much more to trigger that pathway. And what this does is allows us to attack the cell more effectively and attack other cells less effectively. So that's good. We want so-called more on-target than off-target effect as we go through. So this study then was comparing Mezigdomide, one of these new CELMoDs, with carfilzomib dex versus carfilzomib and dexamethasone. And again, you see the same PFS curves that you're all experts in now, where we saw that the average time that patients were in remission was 18 months with the carfilzomib combination versus only 8 months with the carfilzomib combination. Now, I should note that these are patients who are a bit more heavily pretreated than what we saw in the previous two studies, meaning there were some patients that had early relapse, but many of them were significantly more relapse, had 2, 3, or 4. Up to, as you can see here, it said that the range was up to 9 prior lines of therapy. So even with that heavily pretreated population, we saw the Mezigdomide help treat these patients. Well, that's a lot. Talquetamab, Teclistamab, Mezigdomide. All three are not yet approved in that setting that they were, talquetamab with the dara or dara and pom, the teclistamab by itself, or the Mezigdomide with carfilzomib, although we expect because of these phase 3 trials that these are going to be available very soon to all of us. And so I want to turn to our panel now. We can bring up our panel and ask them all, what do you think about all of these combinations? How do we decide between them? And then we're going to get into this critical topic of shared decision making. But Todd, let me give you the first kick at the can here. What do you think about all this research that I've inundated you with now?
Well, Dr. Joe, you introduced those PFS and OS curves saying drum roll, please. And I think following the drum roll should be a round of applause because the results are pretty extraordinary. They really are. And I think it's important that the viewers recognize what you said, that these are very large phase 3 trials, plenary session for the monumental trial, and then published also in top of the top medical journals, in the New England Journal or in the Lancet. And I think that means that they really are worthy of paying attention. If you're a patient, if you're a care partner, if you're a provider, if you're a researcher, these are, like you said, these are the things that tend to change standards of care. And in early relapse, that's where what some of the most heavy action is and the most excitement is. You know, in the guidelines right now, there's a lot of excitement about our current options, which are terrific. We have Carvykti as a first-line option. We also have Tec-Dara. But I think the studies that you just presented in this early lines of therapy could be future treatment options in the not-too-distant future. So like you said, though, how do you pick? We have great options and we're getting more in the not too distant future. And I think that goes down to the point you made around shared decision making. And that's a combination of personal and disease factors. When people are thinking about these different options that they have available, or like you said, even the triplets that were standard of care, because in that trial you showed DPD did well. It's just these ones did even better, which is an amazing reality for us now. But when you're thinking about that, then I think you're thinking about a variety of factors, like what kind of risk do you have, standard, high, or functional high risk? What type of support do you have? What's the rate of rise of your disease? How quickly do I need to make a decision? Frailty, all of those factors fit into it, and then personal preferences too. So there's no right or wrong choice. It's a very personal decision, but shared decision making is the key. So I think that's why it's really great that people are spending time with you and all of us to get educated on the options so they can figure out what's going to work best for them.
Yeah, I really like how you've said that, Todd. It's so important. For those who may not be familiar with the term shared decision making, the concept is there that the doctor just doesn't say, you're going to do this. Or you don't even just go in and say, I want that combination. I always liken things to food. So it's like, a menu that has so many choices on it that you may sit there and have to think about it. Well, do I feel like this today? Well, what's going to best match how I feel and what I'm interested in? Obviously, I'm not trying to belittle a major important decision about treatment, but it really is not just that the doctor says something or that you work together with your healthcare team to make the best decision. Well, what do you think, Diane? I'd like to engage you in this thought as well, because we often say that shared decision making is not just for the patient but also very much so for the care partner as well. So maybe we can bring to keep Todd and Diane on the screen there and ask Diane's input here.
Absolutely. Well, these are not only patient-friendly, they're care partner-friendly options. Both TEC and TALC, in these trials, they go to monthly at around the 6th month, and that's lovely for both patients and care partner. And we always think of care partners as, spouses, but oftentimes it's an adult child that may not be living with the patient that they're helping care for. So they have to travel from their home to wherever that loved one lives, and then to the center. And so a once a month trip to the center for treatment is huge. And then with Majestic, the Teclistamab, it's steroid free at day 5, I believe, if I read that correctly, which that is, care partners love that. Patients and care partners really like the limited use of steroids when possible.
I love that. I really think it's important for us to realize that, as more and more of these newer therapies come into myeloma, many of them really do require quite a bit of participation from a care partner, especially the bispecifics. That may be a differentiator here, for example, for Mezigdomide, where as a pill, that may be less dependent on a care partner, but that really factors in well. Well, Terry, what do you think as well about all of this? I know that you advocate for so many different patients, not just those with high-risk disease, but you always have that high-risk filter on, thinking through it. Well, what do you think about all of these new trials and all these new choices?
Well, I'll turn my high-risk filter off for this. I think you all covered most of it. I think listening to this, what I found exciting is Tec-9 just kind of answered that big question we had after Majestic 3. That was such a great, that same flattening of the curve, but a lot of those patients were not, had daratumumab. So Tec-9 doing Teclistamab without the daratumumab and seeing that wonderful result is really remarkable. The only other things I would say is Mezi. It's very, very interesting. I'm very interested to watch and see that. Not all patients are candidates for CAR-T or bispecifics. Like you said, it's in later lines. So when you get to that point where there are not a lot of options to eventually or hopefully soon have another option with Mezi or iberdomide, that's lovely to see. Also, I read, and I had talked to you quickly about Dr. Joe, that Mezi may also help T cell health, which was intriguing to me. So I'm going to watch that closely with my science nerd hat. And
I love your science nerd hat, and I agree with you. We'll talk about that, I think, a bit when we come to iberdomide, that I think is going to be very important as we use these new T-cell therapies along with the cell mods, that they can often sandwich those therapies, as it were, because they do help preserve T-cell function. I think you also made a brilliant point, Terry, about the Teclistamab combination. So to be clear for the crowd, we now have approved by the FDA Teclistamab and daratumumab together in that early relapse setting. By the way, one of the questions that came in said, what is early relapse? And I want to make sure we don't confuse people. We don't mean early relapse, meaning it happened quickly after frontline therapy. Typically, we talk about early relapse. It means people have had roughly 1 to 3 prior lines of therapy, as opposed to late relapse, which was more than that. But we have that Tec-Dara combination. But as Terry beautifully pointed out, we often find ourselves in a situation thinking, well, I'd like to give them Teclistamab because the response is so good, but they're already on daratumumab as they're progressing, or they have progressed on daratumumab, and in that original study, those patients were not included. Here we have patients that had daratumumab before, and so we hope that we'll have an approval for Teclistamab by itself, because I think that's going to be a very valuable tool in the early relapse setting. Well, I know that was a relatively long first chapter, but we're going to move on to part 2. These ones are a little bit shorter because we wanted to get the heavy phase 3. I mean, it's not very often we could do these post-ASCO meetings and have 3 phase 3 trials. I mean, typically if we get 1, we think that's pretty amazing, but to have 3 of them is even more amazing. But let's talk a little bit high-risk myeloma. We're going to go back to the Majestic 3 study that Terry made reference to. So this was a study that was presented last year, the original Tec-3 study, where we saw this really amazing curve, that almost flat curve that Terry referenced, when we gave Teclistamab and daratumumab together. At 3 years, 84% of patients were still in remission. So that was particularly exciting. But what this study did by one of my dear friends and mentees, Rahul Banerjee from Seattle, is they now looked at that study, but wanted to look more specifically as how did people do if they had high-risk disease, which they defined in 2 ways. First of all, what we would classically call cytogenetic risks. Cytogenetic risk is that when someone has a so-called high-risk cytogenetic feature, something like p53 deletion, or some of those genetic changes that we know are associated with high-risk disease. But they also added functional risk, which we more recently defined as when someone relapses quickly after a first, what someone may have asked when they were wondering what early relapse is. And it's tough the way we use those 2 words, but we think of someone who relapses very quickly or within the first year or 2 after their initial therapy, maybe even out to 3 years. We'll come back to that in a moment. But that's what they wanted to evaluate in the study. So as a reminder, this was the study, as I noted, that had Tec-Dara versus a standard triplet, whether it was DPD, Dara-Pom-Dex, or DV, Dara-Velcade Dex, and showed that really dramatic difference. Then they, as I said, did a subgroup analysis now, and we understand that that isn't always, there aren't always enough patients in the study to capture every detail of the statistical analysis, but nonetheless, they captured those patients that either had high-risk cytogenetics or even expanded version of that where they added a few others, as well as what we called the functional high risk. In this case, they cut it off at 18 months after their transplant or initial therapy. And what they found was as follows. So first of all, in general, you see the red lines are way above those black lines. So that initially tells us that we see a big difference, whether someone was high risk or not, a big difference between getting the Teclistamab and Dara and getting the standard treatment. So it really reassures us of the benefit of this 2-drug combination. But then what I find fascinating is we look at a little bit more detail here. If we look at those that have no evidence of high-risk disease, that 3-year mark, remember I told you the average was about 83, 84%? 90% of patients at 3 years. Now that's a really striking number. But I'm also going to say that striking number is also seen in the high-risk group. Normally we see quite a wide gap between between standard risk and high risk, meaning we expect that high risk patients don't do nearly as well. But here, yes, there's a 10% difference, but it's only a 10% difference. And nonetheless, and furthermore, rather, the absolute number is still very impressive, 80% of patients at that time frame. And then they looked at the number of cytogenetic features, whether someone had none, so you see that 90%. If they had one high-risk cytogenetic abnormality, it dipped down to 82. If they had 2, it dipped down to 76. So the fact that you see that decline does tell us that the way we define high risk makes sense. But we also still see that huge gap between the two different lines, speaking to the power of teclistamab and daratumumab together. So Terry, I hate to call you the high risk queen. That sounds a little bit too intense, but I know that you study this and you think about this for both personal and professional reasons. But how does this strike you? What do you think about this? Are we starting to overcome high risk by using these novel treatments like teclistamab and daratumumab? And what might this mean for patients with high risk disease?
I'll tell you, as a high-risk patient, it's really nice to see this breakout of high-risk patients. We look at studies all the time, and we don't see much about high risk. So it's lovely to see them going back retrospectively and looking at the high-risk population, and then to see that curve. I don't know that it necessarily tells us there's a narrowing, that we're overcoming high risk, but there's certainly a narrowing of the gap between high risk and standard risk. Just to see us hanging out there with the high-risk people is lovely. Usually high-risk responds, but it doesn't last that long. And this was really just showing that maybe isn't as true with these newer therapies. It's good to hear and to see. I would bring up here also, Dr. Joe, the Forte MRD data. When I was looking at all of the high-risk part of ASCO, that's the one that stood out to me the biggest for high-risk patients. And maybe you can comment on that, but what it said to me there is that if high-risk patients sustain MRD negativity for up to 5 years, I think, 3 to 5 years, was sustain that MRD -6. That's where I saw what you're asking here. Are we overcoming high risk? I think it was 83% of the patients remained progression-free, had a good progression-free survival for high risk versus 84% for standard risk. So I'd love to hear a little bit more about that.
Yeah, no, absolutely. I think you're hitting the nail on the head, and we didn't include slides just because we have a lot of slides around it. But that Forte trial was very valuable because it was powered to look at all sorts of things, looking at different combinations, whether or not we need transplant up front. But it had some really good long-term follow-up, as you described. And I think what it is some of you, Diane and Todd, were at our Los Angeles patient family seminar this past weekend. And as we were discussing this, one of the things I said was, I don't want to underappreciate high-risk disease, but I also don't want patients who are given, if you will, the wording of a high-risk myeloma to make it sound like it's a death sentence. And a lot of it is because now we are seeing outcomes overall in myeloma get so much better, and clearly much better in the high-risk area. And that Forte study showed to us one of the things that we believe that can help us overcome high risk. One, we've seen from this study, which is using these novel treatments. But two, working with patients in such a way to not only get them to MRD negativity, but to keep them there. When high-risk patients stay in MRD negativity for longer, there's no doubt the outcome is better. Now, that's kind of a self-fulfilling prophecy, right? People who do well, do well. But what it tells us is that we really have to use that powerful tool of MRD negativity, and we're going to talk a bit more about MRD negativity in the This Just In section, but the power of MRD negativity, and particularly how important it is in high-risk patients. We're going to probably be using more MRD negativity to stop therapy in certain patients. We may not want to stop it in the high-risk patient until they reach a level, as you've described, out to 3 years, where we really see now that the disease has been quiet enough for long enough that we can be okay taking our foot off the gas a little bit. So I think this is tremendous hope for the high-risk population. And I get very, very encouraged, Terry, like yourself, when I see those curves coming together from these kinds of studies.
I would
Maybe
just say
Todd and Diane. Oh, sorry. Go ahead, Terry. Please.
Just the word hope there. It's you don't usually see it with high risk. So I think just seeing that sustained deep response in MRD negativity, you can finally take a little bit of a breath and say your disease is being controlled and that there is hope. And that's what these two studies did for me.
Wonderful. That makes me happy to hear that. Todd, Diane, before we move on to part 3, thoughts around this from your perspectives?
Yeah, just real quick. we know that MRD is the gold standard, and especially for high risk, that is the goal that you may work a little harder to get there. But we also know that there are some patients, Todd being one of them, that are translocation 1114, where getting to MRD negative may take a little longer, may never happen, but he kind of stays low and stable. I've heard you describe it as having Bambi myeloma versus Rambo myeloma in the past, and that just so that patients don't get caught up on that you have to get to MRD negative or else, and there are many patients that can stay low and stable, and Todd being one of them.
Yeah, and we're very glad that Todd is one of them. I was just talking to a patient in my clinic today about this very same thing, Diane, where, we were talking about, she was like, oh, well, the MRD test was not done. And they were very anxious because I think the excitement we have for MRD can sometimes be taken, as you said, a bit too far to the sort of MRD or bust-like thinking. And I always like to give the caveat that there are some patients. One group is the patients with translocation 1114. So if you don't know what that means, you may be able to ask your doctor when they did the original studies on your bone marrow, did they see what we call a translocation 1114? Just means a piece of chromosome 11, a piece of chromosome 14 are connected together. But we also do have some other patients that don't have translocation 1114, where they actually may never achieve MRD negativity, but still do very, very well. In fact, we have some really long-term survival studies from our colleagues in Europe showing there's clearly a fraction of patients. It's almost, Diane, it's almost like they go back to having a little bit of MGUS. That's why I think of it as like the Bambi bit of disease left. It's a very docile little bit of nubbin of disease. Those are typically not high-risk patients. And so sometimes there's just that little bit of disease left. Well, here we're talking about you in the third person, Todd, so I'll let you speak, Mr. 1114.
Yeah, with a smudge of disease of the Bambi cells still remaining. I try to project some masculinity, but I'll take the Bambi action any day of the week, right? I think one thing, I love this, and I think, Terry, and you summed it up beautifully, it gives hope for those that have high risk, or even functional high risk as well, because I think some people hear that, they think, oh no, this is a death sentence. And they can go into a spiral. But this study and others that have reported out, especially those high-risk subgroups with the T-cell targeted agents, can do very, very well. And I just think that's enormously motivating. But it doesn't mean you stop in being rigorous in the monitoring, consulting an expert, because even though you can get these great results, things can move kind of quick. So it's great to have an expert somewhere on your team. It's great to monitor closely, both in the blood and in the marrow, if possible. And I think with whether you have high risk, standard risk, or functional high risk, with all of our options now, you can have a great, full, long life for many folks.
I absolutely agree. I think, the one way I put it, Todd, you may have heard me say this before. I think I even said it this weekend in Los Angeles. I'm the optimistic realist, right? So I start with optimism. I've been a myeloma doctor for almost 30 years. I've never seen a year like this year where we're seeing these phase 3 trials, people living longer, people living better, people off treatment, people doing so well. But the realistic part of me reminds me that there are still some patients, unfortunately, whose disease is very, very aggressive, and it's very humbling. I believe, and I'm thankful to say, that fraction continues to shrink. We've gone from a fairly large portion of patients, and people wonder, why do you keep changing the definition of high risk? Well, part of it is because we're coming to see that with these newer treatments, there's really a smaller and a smaller fraction of patients that really have less response and shortened response. So thank you, all three of you, for your input here. And I think the take-home message for all patients, but including those patients with high risk, is we are getting better at treating myeloma, and the difference between these two groups is shrinking, and there is hope even for those patients who have been told that they have high risk multiple myeloma. All right, well, let's start thinking a little bit about the bispecific antibodies, but now some new ones and some new approaches where I know we all absolutely love the hospital and love to spend nights in the hospital. Of course, I'm being very sarcastic here. No one likes to spend a night in the hospital. As much as possible, we want to keep people out of the hospital, but we also want to be safe. And so when bispecific antibodies first were introduced, they were very much introduced. Everybody got admitted. Most patients were in hospital for at least a week, if not 5 days. And we were very careful to manage them. Now, many of us are starting to do this as an outpatient. I can tell you in our clinic, I try to treat all of our patients, whether it's Teclistamab or Teclistamab or the other bispecifics, linvoseltamab, elranatamab. We try to give these as an outpatient. So we're going to look at two studies. We're going to start with a new bispecific antibody, not yet FDA approved, but being studied from the very start as being able to try and facilitate outpatient management. And then we'll look at another very interesting study that looked at giving Teclistamab and Teclistamab as an outpatient. So this new drug is called Etentamig, and I know it's sometimes hard to pronounce these names. I didn't build it. I get a little tongue twisted every once in a while when I try to say Etentamig 10 times quickly. Etentamig. But it is a new drug. And they studied various arms and cohorts here in this clinical trial. I'm going to try and keep it simple, that there's a couple of things that really fascinated me about the data they presented at ASCO this year. First of all, I really like the fact that they had looked at patients getting Etentamig who had already had a BCMA-targeted strategy. One of the things we're learning about BCMA is that it's a pretty resilient target. So it's not like you get a CAR T that targets BCMA or a bispecific that targets BCMA or belantamab mafodotin Blenrep as an antibody drug conjugate that you get treated for BCMA, and that's the only time you can ever target BCMA. We're learning more and more that actually most patients could get eventually all three of them in the right kind of strategy. So they tested this drug in patients that had had a previous exposure to BCMA and saw, granted, it's a small number of patients, they're just starting out, but they still saw a 64% response rate. So it is feasible to give after someone has already had a BCMA-driven strategy, in particular if it was CAR T-cell therapy. And then secondly, relevant to our discussion right now, they wanted to study Etentamig with, and the SUD here, if you're looking at that, is what we call a step-up dose. So very often in bispecific antibodies, we give a small doses at first to kind of get the body adjusted to it. Because if I just give someone a full dose of a bispecific antibody, there's a chance their immune system is going to react with what we call cytokine release syndrome. So all these hormones get released because basically, and I'm going to offend every immunologist in the world right now, the immune system freaks out a bit, all right? It sort of says, hey, what is going on here? There's all this immune stuff going on, and it releases these things. It can give people a fever. It can affect their blood pressure, their blood, their organ flow to their organs, and it can be a blood flow to their organs. It can be a problem. So sometimes they were testing this with and without step-up dosing, but they specifically wanted to use this in the community, and they specifically wanted to test it in a way to reduce any of that freaking out of the immune system, that cytokine release syndrome. And one of the ways they did that was to give it to patients with what we call prophylactic tocilizumab. I know those are two big words. Prophylactic just means preventative. So I'm not waiting until someone has that freak out. I'm actually trying to prevent it. And tocilizumab is just a drug. We sometimes call it Toci for short. And so for our patients here today and partners, you're allowed to just call it Toci for short. This drug can help prevent that cytokine release syndrome. Now, granted, only 18 patients were in that cohort, but 0% of them, it's easy to remember that number, 0% of them developed cytokine release syndrome. And that was fascinating to me because one of the challenges we've had is that 75% of myeloma patients are treated in the community, not in the big academic centers like Mount Sinai and City of Hope that are represented here, or my center in Honor Health. Most of these patients get treated in a community setting, and it's harder for them to manage cytokine release syndrome and have access to beds in case someone needs to be admitted. So if we could move this entirely to the outpatient setting with strategies like prophylactic tocilizumab, it could be of real benefit to patients. And they concluded that obviously the numbers are still small yet, but there is a real chance that we could do this. The other feature to this drug that I didn't comment on earlier quickly, Diane commented that with the strategy of Teclistamab, that we go down to once monthly pretty quickly, and that's good for care partners. Etentamig is once monthly from the start. So the drug is given every 4 weeks from day one. Well, on the same vein, I wanted to look with you at what was called the OPTEC-OPTAL study. There's a bit of play on words here. They're using outpatient as the op, tech meaning teclistamab, tal meaning talquetamab. And so here, my dear friend Peter Forsberg, not the hockey player, the myeloma doctor, for those of you who know hockey, yes, he's in Colorado. Peter Forsberg is a wonderful friend and a brilliant and compassionate physician, and led this study of saying, can we do this as an outpatient? And there's a lot of data there, so I'm just going to simplify it with their conclusions, and you can look it up if you wish, and hopefully trust us if you don't see the numbers. But what they used was that same prophylactic tocilizumab before their step-up doses for TEC or TAL, and it reduced the rate of cytokine release syndrome by 5-fold, dramatically lower cytokine release syndrome. Secondly, it showed that it actually didn't have an adverse outcome. So people tolerate tocilizumab really well. We don't see a lot of side effects from it. One of the greatest benefits is that it keeps people out of the hospital. So yes, there's a cost to toci, but that cost is very likely overcome and a lot more by keeping people out of the hospital. And then most importantly, this was very feasible because this was not done only in the academic setting. This was done out in the community. So I think this heralds what's happening in what we do with and can do with bispecific antibodies. And so I'm going to come to Diane here as the care partner, because you made comment earlier. What do you think about this less frequent dosing, using prophylactic tocilizumab, maybe doing this all as an outpatient in the community? What does this mean, not only for patients, of course, but for you as a care partner?
I think this is really exciting when you look at all three of these bispecifics you spoke about and the ability to use them in the community setting. I mean, we have fabulous research, but if 75% of patients are treated in the community, we need to be able to get these medicines to the community. I think the Prophy-Toci, as I like to call it, is amazing. As a care partner, we've been married 37 years. He has never willingly gone to the hospital, and so I don't have MD or after my name. I am not a nurse by training. So if I'm caring for him at home and then having to argue with him that no, this fever or the CRS experience that your experience is something that we need to get to the hospital for, it's longer than if we can avoid it altogether. It's well worth it and keep him out of the ER, out of the hospital in general. And if he goes in with fever from CRS and then sits in the emergency room, and he's going to leave with the fever due to the flu or COVID or something, whatever he didn't come in with, he'll leave with on the way out. So just trying to keep patients safe, I think that's huge. And I think anything we can do to do that with the Prophy-Toci, with IVIG use and explaining the importance for patients on bispecifics to have IVIG is really important. And patients and their care partner need to be empowered. You have to get educated and then empowered to really advocate for that with their community physicians.
That's fantastic. I completely agree with you. And this is a team sport. Multiple members of our team on the healthcare side and on your side. Terry, as a patient, what are your thoughts here too about the potential of going towards more outpatient management and less frequent dosing?
Well, can I just comment on Prophy-Toci? I like that.
Oh, please.
That's going to be our little tag from this meeting, I think. I love it. I had the opportunity to go off Kyprolis for a little while. I'm a high-risk patient, so high-risk patients out there, this is where we talk about keeping your foot on the gas. My myeloma started bleeping up very slightly, so back on the Kyprolis every week. The difference between going in every week versus every other week versus monthly, if possible, is enormous on quality of life. And we all talk about quality of life. The doctors talk about, treating and living your life, not just surviving. So anything that decreases frequency and or a pill that you can take at home, I'm all for. The one question I would have, Dr. Joe, you said that there's no increased adverse effects with the toci, and you don't see increased infections either. So just like IVIG with bispecifics, giving them before and preventing infections, why wouldn't we then give toci before anything that causes CRS? if you
Yeah,
have.
that's a great question. That's what's being studied now, right? So the best medicine is the prevention of the disease, right? Or of the phenomenon. And I think, there's always been a hesitation because there's cost involved. There are some challenges in administration and so on. But I think that we're going to see a much greater use of tocilizumab. Some centers have actually really adopted it fully. We try to use it as much as possible. Sometimes insurance is a barrier. Other things can be a barrier. But I think you're predicting the future well. Well, Todd, I'll give you a last word here before we move on to part 3. Any other thoughts about the Etentamig study or the OPTEC-OPTAL?
Yeah, offline, she and I will have a conversation about how difficult I am as far as my willingness to speak up and go to the ER if necessary. But it does speak to the need that, like you said, it is a team sport, and we need to make these things as safe as possible in the community setting, and then we'll really help improve lives for that many more people when these therapies are safely used in that case. I think in addition to the less frequent dosing, which improves quality of life, like Terry said, and the use of these supportive meds, that's a good thing. But the Etentamig trial I thought was really amazing too, because it answers one of those other critical questions around sequencing. Because we now have so many patients that actually have been exposed to BCMA-directed therapy, including CAR-T in particular. I'd really give the folks that did that Etentamig trial a lot of credit for including those patients that had already had a BCMA-targeted therapy, and they did well. So a lot of people have asked that question. If I've already had a BCMA CAR-T, can I have a BCMA bispecific? Well, we know with this particular one, at least it's giving some early signals that, yeah, quite possibly. More research still required, but at least this is a very encouraging sign that we have options within the targeted class categories.
Yeah, brilliantly said, Todd. I think that's just so important as we go forward that we have options for patients. And there was a day where we used to think, if I take a CAR-T or a bispecific antibody or an antibody drug conjugate, I'm burning the other 2 bridges, right? There's only one. But now, as you're saying, this is one of the other studies they're helping us see. No, people can cross eventually both bridges, if not all 3. So I really appreciate that comment. That's really, really helpful. All right, let's move to the last of our parts, that is reviewing the data from ASCO and EHA before we come into our This Just In section. And there's so many things that we could talk about here. But we've tried to look a little bit into the future, and I've selected 3 things quickly to look at here. One is the Arlocell CAR T-cell therapy that has a different target than the 2 CAR-Ts we're using right now, as it targets that same GPRC5D antigen we talked about that's connected to talquetamab. And then 2 forward-looking things about CAR T-cell therapy, something called in vivo CAR-T and something called allo CAR-T, and I'll explain those as we go through. So my dear friend Susan Ball, who's wonderful at the University of Alabama, gave us an update on using Arlocell, as we call it, a CAR-T that targets GPRC5D in patients with so-called early relapse or 1 to 3 prior regimens. It wasn't a large phase 3 trial. This is why we didn't include it in the discussion earlier, but it's still nonetheless an important study with 31 patients that were enrolled in patients with 1 to 3 prior lines of therapy. And there's lots that we could say about it, but I'll cut to the chase and talk a bit about its efficacy and safety. So 94% response rate. So amazing. Another sort of jaw-dropping treatment that we're seeing with CAR T-cell therapy. We've come to expect now an over 90% response rate with CAR T-cell therapy. It's a little bit early to detect how long because of the length of the follow-up, but nonetheless, you can see here that 94% responded, 71 went into complete remission, and those who are valuable, 65% got into MRD negativity in light of what Terry shared with us earlier and the importance of not only getting to MRD but staying in MRD negativity. Now, there were some challenges with this. We saw pretty typically the cytokine release syndrome and some of the early, what we call ICANS, and neurotoxicity that tend to be lower grade and not higher grade. But there were a couple of other ones that were a little bit different, what we think of as other neurotoxicities and these OTOT or, off-target effects that can make us a little bit concerned. When those were looked at, they were thankfully lower grade, but we saw some of the things that we expect to see with targeting GPRC5D. So for those of you who understand the drug Teclistamab that we discussed earlier, I didn't have time to get into some of the side effects, but we have GPRC5D on our taste buds, on our nails, on our skin, and sometimes there's some of that so-called off-target effect, meaning it's not hitting the myeloma, it's going off to hit something off target. And we're working very hard to narrow the target more and more to only hit the myeloma cells, but sometimes there's a bit of so-called friendly fire and it hits other parts and other tissues. And so we can see people have nail changes. It can affect their taste buds and their ability to eat and cause weight loss. And we can also see that it affects their skin as described here. So thankfully they were lower grade and they were what we call grade 1 or 2, where they tend to be resolvable, but it's just something that we have to keep an eye on as we go forward. But that being said, this is being studied further in what are called the quintessential studies. I told you you're going to hear some good names of studies today. But this was really encouraging to see that we could see this over 90% response rate that we see at a year and a half, 100% of patients were still alive and over half of them were still in remission. So I think this is going to be fascinating to us because even though Todd, shared a few minutes ago the importance of being able to go from one from one BCMA strategy to another BCMA strategy, there are times where we may want to switch the target. And having a CAR T, just like we have a bispecific antibody with Teclistamab that has a different target, now we have a CAR T that looks at a different target as well. Now, the other area that was quite fascinating was this whole notion of in vivo CAR T. Well, what does that mean? Well, right now, if we do a CAR T cell therapy, I would take T cells out of a patient, and we use the word ex vivo for that because it's coming ex or out of their body vivo. And in the lab, we are manipulating their T cells to become CAR T cells so that we can give them back to the patient to fight their multiple myeloma. This study evaluated in vivo CAR T, which means we didn't take it out of the patient at all. We actually just gave a patient a medication that went to their own T cells and converted them to CAR T. And the benefit of this is multifold. One, you don't have to collect their T cells, so you don't need all of that. For those of you who've been through it, you may remember, for those of you, for example, who've gone through stem cell transplant, you know what it's like to sit on that chair and get your stem cells collected. Waiting as you sit there for hours, and the hospital has to have that dedicated bed and has to have the machinery. We skip all of that. Number two, typically in ex vivo CAR T, in the CAR T we do now, I have to give some patients a little bit of chemo before I give them their T cells back. So we don't have this epic T cell battle between their existing T cells and the ones I'm giving them. Here, because we're not giving them external T cells, we can skip that, what we call lymphodepleting or chemotherapy. And so this has the potential to give our patients less toxicity or less side effects because of that lymphodepleting chemotherapy. So the concept of in vivo, and I got to put my equity hat on for a moment because it's so important to me. We have such disparity, not only in this country, but across the world. When I hear about being able to give someone in vivo CAR T, meaning use the great technology of CAR T without having a big center that does T cell collection and has to face some of these other side effects, this could be a real answer. What was fascinating at the study, we heard about in vivo last year with 3 patients. Well, now we have 18 patients that have been treated, and all 18 achieved MRD10 negativity in the first month. Now, there has been a patient that's relapsed, so we know it's not 100% as perfect, but that is still pretty jaw-dropping to think that we could potentially have this kind of impact with an in vivo CAR T. And then lastly, allo CAR T. Well, allo CAR T is kind of even taking this concept a step further. Now, instead of giving someone a medication to change their Ts into CAR Ts, I collect T cells from a healthy donor. And we create CAR Ts in the lab. In fact, we've just about to open a allo CAR T trial at my center. It's pretty complicated technology, to be honest, because we've got to create T cells that the patient is going to accept. Because in those earlier, in the ex vivo and then vivo, those are someone's own T cells. They're not going to reject them. But here, there's a risk of rejecting them. There's also a risk that these T cells are going to start to fight other things and not just myeloma. And so we want to be what sometimes we call graft versus host disease. So where those T cells that are come from someone else gets into another patient, says, hey, wait a minute, this is not me. I don't like this. I like me. I don't want to be in something else that's not me. And it can go attack that situation. However, we're working very hard to manipulate these T cells so that they don't have that feature. We don't have a lot of results. I won't go through them for sake of time, but there was, even just initially in these 12 patients, 11 of them responded. So to see that over 90% response rate was very, very impressive. And I think tells us that it's worthy of us to start to discuss this a little bit more. So as we think about this, and let's bring all three of our guests onto the stage with us. What excites you about these things? I'm happy to have everybody chime in, but I think maybe you'll start with Diane. And what do you think about this Arlacel, targeting a different antigen for CAR T cell therapy?
Well, I think it's amazing. For so long we've had the BCMA CAR Ts, but now to have a GPR C5D option is huge. And this novel agent could make the difference for someone that maybe didn't respond as well to the first two CAR Ts, but could have success with Arlacel.
And what do we think about the allo CAR T? Terry, do you want to comment on that one?
Yeah.
Oh, you're on mute, Terry.
Sorry.
No worries.
That one I find most myeloma patients are excited about and are really, really waiting for that one. Just think about no lymphodepletion. That basically says it all. And for the allo CAR T, that one is pretty intriguing to get T cells from healthy donors. I'm finding a pattern that I have here and ending whatever statements I have with a question for you, so I don't want to disappoint, and I'll end my statements with a question again. I do worry about the AlloCAR T. Sounds so exciting, especially because it's from healthy people, but with that graft versus host disease in the few patients that they've treated so far, have you seen that?
Yeah, so that has been an issue. I think we're overcoming it a little bit because we can learn, just like we've learned from the allo transplant world, of how to minimize graft versus host disease in the way the cells are prepared, and potentially even other things that we can do. It is a real issue for sure, but it's that delicate balance, as you said. What people may not have fully appreciated from Terry's comment is that one of the things we get concerned about is as you treat myeloma with multiple lines of therapy, it does kind of beat down a patient's T cells. So the attractive nature of a healthy T cell donor means we may have a more robust T cell. The problem is we don't want it too robust either, right? We don't want it to start going after things that it's not meant to go after. But I think we're getting better at that, Terry, and I think we understand it a little bit more. Todd, I'll give you the last word before we move to this just in for our last few minutes before we dive into these 38 questions that have been asked already.
I think when I look at those three trials and those three drugs that you mentioned, I think you used the words jaw-dropping. When we're seeing 90+% response rates, I think that's pretty amazing and hope for the future. The other thing it kind of just reminds me, in each of those trials you showed the swimmer plots, and those swimmer plots show individual patients. And I'm just thinking about those people that said yes to these trials, these early trials, and in that clinic setting, they see the results and the celebration that probably happened in that moment when they were able to benefit from these innovative therapies. And these are early trials, the numbers are small, but that might be the future down the road for many of the reasons that you just described. So it just reminds me of the power of clinical trials. Whether you are high-risk smoldering, whether you're newly diagnosed, whether you're in your first to third relapse or in later relapse, it really is an extraordinary option for patients and their care partners. And these trials, I think, really just speak to the value of that.
And
I love that,
Joe,
Todd.
can I add one sentence there?
Please.
It's anybody who knows me has heard the sentence ad nauseum, but when I went to see my myeloma specialist with plasma cell leukemia, it was such a dismal outcome. He said to me, the longer I keep you alive, the longer I can keep you alive. And looking at all of these studies, that's what I think. The longer we stay alive, the longer we stay in remission, the more we have available to us. And that's just extraordinary.
I love that. I just, that's why, I'm the appetizer here. You guys are the main dish. Like, this is really remarkable to hear that from you. And I obviously so heartily agree with you. And I'm so grateful for those patients who went on to those trials. Sometimes people think, I go onto a trial to help the community at large. I almost feel like it's like you're donating your body to science after you die. That's not what's happening. These patients benefit themselves. And when people go on to clinical trials, the goal is to benefit them. Well, time's going quickly. I want to leave you with this slide. I'm not going to read it all. I'm just going to have it up for a few seconds, kind of summarizing for those who've been doom scrolling and not really listening. And you really want to get everything that Dr. Joe, Todd, Diane, and Terry shared in the last hour and 4 minutes. This is the summary of it all. And it really is amazing what's happening in relapsed multiple myeloma. And that's been primarily our focus today. But before we move to the Q&A, I can't help but talk about what has just happened. Oh, there's so much to talk about. This could go on for a long time, but I'm going to keep it very brief. 3 things. A new delivery mechanism for Teclistamab, a new approval from the FDA with a brand new drug, Iberdomide, and really important results of a clinical trial, the Endurance trial. So Teclistamab, as we all know, or Sarclisa, is a CD38 antibody, very much like daratumumab, that we give to patients and is approved in frontline and in relapse settings. Historically, we've given it intravenously. They've developed recently a pretty standard subcutaneous push, but now they have this whole new mechanism of what's called an OBI, on-body injector. And the picture here doesn't capture it all, but I want to just give you a quick sense of what happens here is that the drug comes in a little vial, only 10 milliliters. The pharmacist doesn't have to mix it, doesn't have to prepare it. We don't even have to weigh the patient because it's standard across all weights. And it gets put into this little plastic device that, okay, I'll channel my inner hockey Canadian here. It looks kind of a bit like a hockey puck. It's even smaller than, frankly, a hockey puck. And it's a lot lighter than a hockey puck. I'll give you that. And this little hockey puck has a sticky end that gets pressed into, just placed on a patient's skin. And there's a little button there that the nurse, the healthcare professional can push, and it starts the mechanism. And over the next 12 to 13 minutes, this tiny little needle sticks into the skin. Like when I say tiny, it's only a 30 gauge needle. So this is about as small a needle as we have. And it infuses the drug into the patient over the next 12 to 13 minutes. And this just got approved by the FDA. And I mention it because in one of the clinical trials that was just published in the Zelco study, they gave patients both. The same patients got 3 cycles of one, of just giving it through a subcutaneous push or getting it through the OBI. And those patients really preferred the OBI. 75% of them preferred. In fact, when they got given the choice, which one do you want to continue? 90% of them stuck with the OBI as opposed to the subcutaneous shot, as did the healthcare professionals. The nurses found it easy to administer, and it gives them more time to be able to talk and interact with the patient instead of staring at their gut while they push in this drug over 7 minutes. So it really is a remarkable new approval that we've just had. And so secondly, we also had another approval just last week, August the 13th, less than a week ago. Talk about the timing of this new drug. And I talked a bit about it earlier, called Iberdomide. It's the first drug of this new class of drugs called CELMoDs that squeeze that cereblon to trigger the destruction of multiple myeloma. The trade name of the drug is called Zenbexus. I don't really know what that means, apart from saying that it makes me feel a bit zen. But Zenbexus is going to be the new name for Iberdomide. I showed you this picture earlier, but just as a reminder, the IMiDs kind of press on cereblon and the cell mods squeeze it, and that's how this drug works. And it was just approved in combination with Darzalex in patients with early relapse. And based on the conversation we had earlier, and I'll get everybody's take on this in just a second, it was very encouraging for us to see a drug that is a pill that can be given. That will really help patients who live far away, who may not have a care partner and have all the challenges that there may be with some of these new immunotherapies. Lastly, we had a very important study published called the Endurance trial. I teased the first author here, Shaji, because he's a close friend of mine, that you need endurance to wait for this study, because this study was started 13 years ago. I was still at Mayo Clinic at the time working. I was part of the study in the early days. And what this study did, it had two parts. I'm just going to talk about part two. When patients who are not high risk, who are not going to transplant, but were after their induction treatment of about 9 months, they were given maintenance therapy in one of two ways. They were randomized to get 2 years or continue until the disease relapses. And the bottom line was the key measure of the study, the primary outcome, was overall survival, and there was no difference, whether you got 2 years of Rev or ongoing Rev. And yet, those patients that had ongoing Rev definitely had more side effects from it. So this is starting to break this thinking of, well, we should really just keep people on treatment forever. We may be, at least in this non-high-risk setting, we understand that, as we discussed earlier, it may be different for the high-risk setting, but this is really exciting news. I even had a conversation today with a patient about this who was he was a little bit further. He was at the 3-year mark, and we said, you know what? I think we have enough evidence now to stop his Revlimid. He said, are you kidding me, Dr. Joe? I have 7 pills left. Are you telling me I'm taking these 7 pills and then I'm out? I'm like, you are starting nada next week, brother. And he was very, very happy with that. Well, let me quickly ask the group here, what do you think about this OBI, iberdomide, and the Endurance trial? And whoever wants to go first, it's up to you.
Go ahead, Terry.
Terry, you're on mute.
You're on mute.
Sorry, guys. I should do that as soon as Dr. Joe starts. I want to be very quick because I really want Dr. Joe to get to questions. OBI, I love it. I would definitely go for that. And just the high-risk people, that endurance data is so exciting. Maybe not for us, but good for the rest of you.
Fantastic.
I would add that innovation comes in all sorts of forms. It can come in form of the drugs. It can come in form of the delivery mechanism. So anytime we can move from IV to sub-Q is great. And the fact that we now have IBER as an oral option, a very effective new oral option, I think is also great. So it's not only the results, but it's also the experience. So this is all great. And Endurance is a game changer too.
Yeah. I think the key with Endurance is just having a conversation with your myeloma specialist. You know, you don't want too little treatment. You don't want like too much. It's the Goldilocks, find what's right for you, which may be different. And then the continued monitoring. It's not like 2 years and you're done and you don't have to go back and see Dr. Joe anymore. You need to still be, you know, having testing, having, you know, bone marrow biopsies, whatever it is that you and your specialist need. It's not just 2 years and you're out of there. It's continued.
And you know what I love about all three of these, that you know, obviously I didn't orchestrate them because they all just happened in the last few weeks, but all three of these speak to that truth that I always say, I don't treat myeloma, I treat people, right? The OBI is meant to make the experience, as you said, Todd, smoother. Iberdomide, an oral, easily tolerated drug. I mean, I didn't get time to dive into the details of it, but we found it, and I've used it in trial. It's easier than Revlimid. There's less diarrhea, less cramping, less low blood counts, and less fatigue. And the Endurance means we can treat people for shorter periods of time. So all of these speak to that experience. And it excites me that these are the kinds of things that are making headlines. It's not just new technologies. We love the new technologies and the fancy schmancy drugs. But here, this little plastic device, it's pretty impressive, but this little plastic device can really make life easier for patients. Well, we only have 15 minutes left. I'm sorry that I sometimes get excited and chat. I'm going to do some rapid fire answers and then bring back the famous BB, Becky Bosley, to close us off at the very end. But let me try and hit as many of these questions as we can. I will say that I'm going to be in the studio in a couple of weeks answering more questions. So if we don't get to your question today, I apologize, but please keep sending them in. We keep a list of them. Poor Jason, who works at the IMF, keeps this massive list of questions, and he gets me to try to answer as many as I can. So this is the rapid fire round of questions with Dr. Joe. Can you explain what an M-spike classified as oligoclonal means? So the M-spike is that measure of the abnormal protein that we do in the lab. And we use the word oligoclonal typically in two ways. One, sometimes after someone has had something like a stem cell transplant, instead of seeing one spike, we actually can see several little spikes. At first, we get scared saying, uh-oh, this person's got a lot of myeloma. Actually, it's not myeloma. It just means that the immune system is coming back vigorously, and it's a good thing. So typically, oligoclonal banding or oligoclonal means a very good thing. Sometimes we may use the word oligoclonal when we talk about someone who doesn't have very high M-spike. It's always a little bit on the lower end, and that's a whole separate conversation. Number two, is blood work enough to flag a potential relapse? The quick answer is almost always, but not always. It depends on someone's myeloma. Most patients, we can follow their myeloma in their labs through their M-spike or their light chain. Some only get detected in the urine, and some may have extramedullary disease that's not measured in the blood or the bone marrow and has to be measured on X-ray. And some may only be seen on a bone marrow. So yes, we follow blood very closely in patients, but sometimes we need to look at more. I started my induction therapy for drugs in March, 3.2 M-spike. It's been 0.2 since June. It's remained the same. Can this be considered remission? Well, first of all, congratulations. I'm so glad it's gone down so much. It is absolutely a form of remission. Remember, we defined remission as saying as long as that M-spike's cut in half. So as long as you got below 1.6, you have what we call a partial remission. If it got down below 0.3, it's called a very good partial remission. If it gets down to 0, it's called a complete remission. Yours may be complete because if it's stagnating there at 0.2, it's quite possible that the daratumumab or isatuximab, because you mentioned a 4-drug combination, that may actually be the drug itself. Believe it or not, those drugs have a bit of an M-spike themselves. So both the disease and the drug show up in the same way. You can discuss this with your doctor, and they can do special tests in the lab to determine if it's the same one. How rare is a brain plasmacytoma? It's very unfortunate when it happens. Thankfully, it is really quite rare. This happens in less than 1% of patients. Even if we just look at all of what we call CNS or central nervous system myeloma, where myeloma gets into the fluid that bathes the brain, it may be in the brain or in the spine, upper part of the spine. So this is really quite rare. It's challenging to treat. We typically use both the chemotherapy or treatment we would give through the blood, and sometimes we give treatment right into the CNS through a spinal tap or through a needle in someone's back, and sometimes we may even add radiation to that. Why are no studies conducted on how to prevent or minimize recognized side effects before requesting FDA approval of a new drug? Well, actually, I mean, it's an interesting question the way it's worded, but that is the goal as we do so. We want to detect the maximum benefit, but also the minimal side effect. And so as we test drugs and study them, we very carefully to capture side effects, because we'll determine that a drug may not be eligible to be approved if it has too much side effects. So yes, I think historically a lot of focus was on let's just see how much response we can get, and we used to call it we still call it the maximum tolerated dose, but there's been more emphasis, I would argue, of late on what that tolerated really means. Because more often than not, drugs, after they get approved, we tend to use lower doses of them to keep the side effects down. So I really like this question because it's telling us that it's very important for us to recognize side effects and not just efficacy as we go forward. Can you please post a link to the slides? Yes, that Becky's going to come and share with that in a minute. We've already answered one question about early relapse, so I'll go to this one. I think there are two questions that ask the same thing, essentially. Is it possible to have a liquid biopsy from regular blood or serum to find myeloma markers such as next-generation sequencing or next-generation flow without invading bone marrow biopsies or using mass spec? The short answer is we're working on it. And I know I've been saying that on these seminars for the last couple of years, but we are making slow and steady progress so that we can have the technology that is sensitive enough to detect bits of myeloma in the blood without having to go to the marrow. On the other hand, I don't want to make it sound like we're totally abandoning bone marrows. Bone marrows will likely always be important, especially at the diagnosis where we can get a large amount of the tissue to understand the disease. But I'm hoping that with time, we can get into sort of a balance of using less bone marrows to follow MRD and more peripheral blood, whether it's through NGS, NGF, or mass spec, as the question asked. I think all three are valid ways of doing it. What if on DPD for 3 years in remission, would you change to a bispecific be a good idea? Well, the old adage of, hey, if it ain't broke, don't fix it. We typically don't change treatments if someone's in a remission, tolerating it well and not experiencing side effects or experiencing damage to their organs. So this is obviously something to discuss with your healthcare team, but typically we would make a change when there was disease or evidence of disease growing so that we can overcome that. It's hard to, if you're already in remission and there's no evidence of disease, starting a new therapy, it's hard to know how well it works apart from being on it for a very long period of time. And bispecifics, more often than not now, we're trying to reduce the time that people are on it. Are insurance companies covering the cost of Mezigdomide? What is the cost without insurance? Well, to be clear, Mezigdomide is still not yet FDA approved. So this will not be covered by insurance. Iberdomide just got approved last week. So now we have access to Iberdomide in combination with Darzalex in relapse myeloma. So Mezigdomide is really now only available on a clinical trial. Is there any associated quality of life data associated with any of these studies? Absolutely, yes. I wish we had time to review them all and go into great detail. We're going to hear more a lot. Basically, what happens when these studies get presented at a meeting, they get presented, the data is summarized, and then the full paper comes out. And for some of them, for the big trials that I reviewed with Todd initially, they have come out and there is quality of life data. I'm very encouraged by the fact that we really push now for quality of life data to be provided in these studies, because it's not enough to just say someone is alive or without remission. We want them to live and to live well, as Terry shared with us earlier. Which one is better on proteasome, Velcade or lenalidomide, Revlimid maintenance therapy for 2-year, 5-year, 10 years or longer for multiple myeloma? When is a better time to stop maintenance therapy under MRD or other algorithms? This is a perfect question because it comes right at the time after we've done the endurance trial. So in simple way of thinking, we have historically felt that if someone does not have high-risk myeloma, that lenalidomide is the most appropriate therapy for maintenance. There have been some studies that have added Velcade, added Kyprolis, more recently added daratumumab, and there's evidence that that may help even a little bit more. But I think most of us are generally giving Revlimid alone, or maybe with daratumumab because it's so easy to take. In high-risk situations, that may be different. That's where we're typically adding 2 drugs or giving 2 drugs as maintenance and adding either daratumumab or Kyprolis or Velcade to the Revlimid. I think we've learned that from the endurance trial that 2 years is probably enough in non-high-risk patients who've been on Revlimid. In high-risk patients, it comes to the discussion that Terry and I had around the Forte trial, which is that MRD is not just important to achieve once or maybe even twice a year later, but maybe even 3 years of MRD negativity before we think of stopping treatment. My last comment here, though, that is so important is remember, our tolerability of side effects should change when we're talking about people being on something for years. It's one thing to say you're going to be sick for the first couple of weeks on a bispecific or a couple of months with transplant. If someone is really experiencing side effects over the long haul with maintenance therapy, we really have to think about whether or not that's the right strategy. Because as I said, we treat people, not disease, and we want to make sure they're cared for. All right, we have 6 minutes left, so I'm going to take a couple more questions and bring it back to you, Becky. Someone says here, is Mezi and Tec still an option in relapse despite the use of daratumumab? Great questions. Maybe I think someone is probably referring to Iber or Tec because they're both approved now with daratumumab. If someone has been on and has progressed on daratumumab, we're typically not giving them the Tec Dara or the Iber Dara combination. As we commented in that study that I reviewed, that teclistamab alone may likely be an option in the near future if it is FDA approved. With the IBER study, we have not seen that. With the Mezi study that is still obviously under investigation and the FDA is reviewing it for potential approval later this year, we may be able to use that Mezi carfilzomib combination in patients that have progressed on daratumumab. And then lastly, someone says, can we get study results broken down by the type of myeloma so high-risk people can choose what is most effective? Well, you're getting an amen from Terry here. And that's why I'm thankful that these larger studies, because you really need a larger study to show the difference, right? If you have a study of 80 or 90 patients, it's hard. And if only 10 or 20 of them are high risk, it's hard to really prove that. But in these larger studies, we are seeing very careful inclusion of high-risk patients and that breakdown. And hopefully we gave that to you with the Majestic study as we showed you, and hopefully more studies will come with that through time. I wish I could get to more of these questions, but I am allergic to being late, and I really want us to finish on time. So thank you for the other 20 questions that I didn't get to. We're up over 53 now. Oh, my goodness. But let me turn it back to you, Becky, so that you can wrap things up for us. And again, thanks so much to Terry, Todd, Diane. I love the three of you so much, and I appreciate your input today. Back to you, Becky.
Thanks so much, Dr. Joe, Todd, Diane, and Terry. How incredible of a webinar this was. Sharing the patient and care partner viewpoints on all of this important research is so important. It makes it real life, right? It puts it in our homes and it puts it in our lives and makes sure that we are living well with myeloma. And that really is the goal all along. So very quickly, I just wanted to review a couple of last housekeeping slides. We will again be sending out the replay and the slides to you in the coming days. You will receive an email for that, as well as that good old feedback survey that we will be putting on your screen at the end of the webinar, as well as attaching to that email that you will receive in the next few days. Please do take a moment to complete this survey. We really want to hear your feedback. And once again, thank you so much to our sponsors. Without you, we would not be able to provide this level of education to our community, and we really appreciate you. GSK, Johnson & Johnson, and Sanofi. Thank you so much, everyone. Have a good evening.